Okay, this week's lecture is on clinical masking for pure tone and speech audiometry. Our objectives are to understand why the non-test ear needs to be masked, to obtain true thresholds in the test ear, to know what is meant by intraoral attenuation and those minimum intraoral attenuation values used for each different transducer when making decisions about the need to obtain masked thresholds, to recognize from the unmasked thresholds when masked thresholds must be obtained, apply the decision-making rules for masking when testing by bone conduction and air conduction using supraoral earphones, circumoral earphones, and insert earphones. Describe the types of maskers used for pure tone and speech testing. Define effective masking or effective masking level and how maskers are calibrated in the audiometer. Describe the occlusion effect and why this needs to be considered when bone conduction masking is used. Describe two advantages of insert earphones over supraoral earphones as they relate to masking. Define what is meant by masking plateau and how much of a plateau is appropriate. Discuss why the width of the plateau is smaller when there is a potential moderate conductive hearing loss. Apply the specific steps for air conduction and bone conduction masking using the plateau method for a variety of unmasked audiograms. Define overmasking and masking dilemma and recognize situations in which these may occur. These are both different concepts, but you need to be aware of both of them. Apply the specific steps for air conduction and bone conduction masking using the plateau method for a variety of unmasked audiograms. There are different masking methods, the plateau method being the most common method and the most well-researched method, so it's the one we'll focus on today. Here's an example of a masking profile where you have tone in dBHL, which is the level that the patient is responding at, versus the masking noise applied to the non-test ear. And we can create a plot, not that we save clinically for a patient's record, but for our own practice and understanding of the masking procedure. We have an area of undermasking, an area of plateau, and an area of overmasking. This will make more sense as we go along, but I just wanted to show you this initial diagram since you're probably not familiar with seeing a masking profile like this. What it represents again is the pure tone level in the test ear being responded to on the y-axis versus the masking level in the non-test ear on the x-axis. So intro. Pure tone thresholds are only useful if they are accurate representations of ear-specific hearing sensitivity. However, there are situations where the stimulus is detected by the non-test ear, where we don't want that. It's a source of error. So that would be bone conduction testing at any level. That would be air conduction testing at moderate to high levels. This is most often problematic with the better ear, not when the non-test ear is the better ear, detecting stimulus intended for the worse ear, or the test ear. Air conduction masker noise delivered to the non-test ear during testing presents a risk of crossover back to the test ear, impacting test outcomes. That's what we call overmasking. When a patient detects sound presented and heard by the non-test ear, it is referred to as cross-hearing. Again, when a patient detects sound presented and heard by the non-test ear, presented to and heard by the non-test ear, it is called cross-hearing. I just had an error that I fixed in the PowerPoint that I want to rephrase here. I mistakenly said that incorrectly. Let me correct that. When a patient detects sound presented to the non-test ear and it's heard by the test ear, it is referred to as cross-hearing. So when you present masker noise to the non-test ear and it's heard by the test ear, that's referred to as cross-hearing. The patient is instructed to respond to the tone, not the noise, during masking. Sometimes they are confused by that. It's not uncommon for a patient to respond to the noise initially, and then you require re-instruction. That's a very common thing to encounter. Clinical masking always involves the masker noise in the non-test ear and always via air conduction. The stimulus to the test ear is either via air conduction or bone conduction, depending on if we're conducting air conduction masking or bone conduction masking. Here's an example of a picture of someone with a supraoral earphone where they've got the masker in the left ear and they've got the bone conduction oscillator on the right ear. So that's a right ear masked bone conduction threshold, because the occluded ear is the left ear, the non-test ear, which is getting the air conduction masker, and the stimulus ear is receiving bone conduction stimulation through the right bone conduction oscillator. Clinical masking is intended to take the non-test ear out of the picture when obtaining results for the test ear. First, we should talk about a concept called intraoral attenuation. When the level presented to the test ear is sufficient to vibrate the bone, both cochleae are being stimulated. But that doesn't mean both cochlea are being stimulated at the same sensation level. Intraoral attenuation refers to the difference in signal level presented to the test ear versus the signal level at the non-test ear via bone conduction. In other words, at what level does cross-hearing start to occur? Clinical masking to the non-test ear is indicated in these circumstances. While average intraoral attenuation values have been studied and reported, we are most concerned with minimum intraoral attenuation values for clinical masking. This is a very important point, and I want to emphasize this. We are concerned with minimum intraoral attenuation values. The average intraoral attenuation value is relevant to know and understand, and it's relevant to the average test patient or subject, but it's really the minimum values that we use when we're calculating when to mask, because we're erring on the side of caution. So here is a table of minimum intraoral attenuation values that are used across frequency for clinical usage. Now bear in mind that often, not always, but often these intraoral attenuation values do vary across frequency for clinical usage, but it's most common for us to use one number clinically so we don't have to memorize different numbers for every octave frequency. So the bone conduction oscillator has a 0 dB intraoral attenuation factor. So that means that if you have equal hearing in both ears and you present a bone conduction stimulus, you don't know which cochlea is being stimulated. It's generally the better hearing ear, but if there is no better hearing ear because hearing is equal, you don't know which cochlea is being stimulated. And it could be both cochlea being stimulated. The minimum intraoral attenuation value for supraoral earphones and circumoral earphones will use is 40 dB. Now, in the textbook, they say insert earphones have a minimum intraoral attenuation value of 55 dB. I want to add a caveat to that. That is assuming deep insertion of an insert earphone. If we have shallow insertion of an insert earphone, then our actual intraoral attenuation is closer to 40 dB. Now, for most of the examples we'll be using, we're going to assume deep insertion of an insert earphone. But clinically, you should not always assume that. If you have a patient with shallow insertion of an insert earphone, I would recommend that you treat it as 40 dB intraoral attenuation so as to err on the side of caution. If you want to know what actual intraoral attenuation values are based on the newest available data that I've compiled, not from the textbook, but from the newest available data, this is frequency-specific intraoral attenuation values. They show it in graphical form here on the top and in tabular form here on the bottom. You can see that across the board, it is 0 dB for bone conduction oscillators, which is what we'd expect. For supraoral headphones, It is the 40 dB up to 1000 hertz, but at higher frequencies from 2000 to 8000 hertz, you can see that actual minimum intraoral attenuation value is higher, 45 to 55 dB. For circumoral earphones, it's very similar to supraoral. It's 42 dB across the board, so using a 40 dB number is pretty reasonable to use with circumoral earphones. And here's the distinction I make between the textbook and the newest available data. Insert earphone intraoral attenuation at low frequencies for shallow placement is 40 dB, and high frequencies it gets up to 50 dB. But for a deep insertion, minimum is 55 dB, getting up to as high as 70 dB. So it just depends on the frequency. Now, if you choose to have a table in front of your audiometer showing you these actual minimum intraoral attenuation values by frequency so that you don't have to mask as often, and that would be the main benefit, masking less often, all the power to you. That's even more accurate if you'd like to do that. But just to let you know, it's not terribly common to do. And to let you know, the clinical masking criteria for air conduction masking is when air conduction in the test ear minus intraoral attenuation is greater than the bone conduction in the non-test ear, bone conduction threshold in the non-test ear. That's how you know when to mask. That'll come up again and again in different ways, so don't worry about that too much right yet. So again, deeper insertion, the benefit there is it reduces the need for masking. Inserts in general have less need for masking than headphones do, but you can see that a shallow insert placement is not necessarily any better than a supraoral headphone, and barely better than a circumoral headphone. It's really with the deep insert placement that you have the benefit. Now, what about intermediate insert placement? Well, that's the question now, isn't it? There is oftentimes the case is when you have intermediate insert placement, so you might adopt something more conservative, maybe a 50 dB minimum intraoral attenuation value instead of 55 if you have an intermediate insertion, because you don't always know. If you have shallow, it's obvious because you're not flush. If you have deep, you're going to be going a couple millimeters beyond the ear canal entrance. But if you have intermediate, usually you're just flush in general. And that's the most common placement, in my opinion. So let's talk about maskers for a moment. When we're engaged in pure tone masking, we're using a narrow band noise. This is used for pure tone audiometric masking. These maskers are about 1/3 octave wide. As you learned in acoustics, this is an example of a band pass filtered noise. The center frequency of the narrow band noise in the non-test ear matches the pure tone frequency presented to the test ear. So a 2000 hertz narrow band noise, which you would use for 2000 hertz pure tone masking, has the same center frequency. It's just broader in bandwidth. You usually need a 2-channel audiometer. I say usually because you can have a 1.5 channel audiometer and that will work. Pure tone stimulus is routed through one channel, narrowband noise through the other channel. Narrowband noise maskers are calibrated in effective masking level so that X dB of narrowband noise shifts the pure tone threshold by X dB. So whatever level you have on the masker, it should shift the threshold by that amount, assuming you have a 0 dBHL threshold. So here's our example of 40 dB EML effective masking level. Masking shifts the threshold to 40 dBHL. That's assuming a 0 dBHL threshold. So say you had a 20 dBHL threshold and you apply 60 dB of EML, 60 dB of masking, it's going to shift your threshold to 60 dBHL. Let's talk about a different concept for a moment. We talked about masking for a minute there. Let's talk about something different called central masking. Happens when you present a mask or noise, be it narrowband noise or speech-shaped noise, to the non-test ear. It's a small elevation threshold in the test ear when clinical masking noise is presented. This can occur even when below intraoral attenuation levels. So even if you only have 30 dB EML masking, this can cause central masking. This is because it's related to a centrally mediated phenomenon. It's assumed that this is caused by efferent stimulation from the medial alveocochlear bundle. Oftentimes you'll see reference to the medial alveocochlear bundle of the superior olivary complex referred to in OAE suppression or OAE contralateral suppression. It's one way you can measure the efferent function of an individual. It's not typically a clinical test. It's done more in research related back to hearing and noise. Central masking increases with masker intensity, but it's usually only about 5 dB and not clinically significant. So let's talk for a moment, shift gears, about when is masking needed. When we need to mask, the if-then condition followed by the practical rule. So for air conduction testing, the stimulus presented to the test ear is actually detected by the non-test ear, thus resulting in erroneously low detection thresholds for the test ear. For supraoral earphones, when the obtained air conduction threshold in the test ear is worse than either the non-test ear air conduction threshold or the bone conduction threshold, unmasked or masked in the non-test ear by at least 40 dB. That's when we need a mask for supraoral or circumoral earphones. Or for shallow inserts for that matter. But for a deeply placed insert earphone, when we obtain the air conduction threshold in the test ear, if that's worse than either the non-test ear air conduction threshold or bone conduction threshold by at least 55 dB, that's when we need to mask in that situation. For bone conduction testing, it's a little different. We know we have a 0 dB intraoral attenuation, minimum intraoral attenuation value for bone conduction oscillators. So when the stimulus presented to the test ear is actually detected by the non-test ear, this can erroneously lower detection thresholds for the test ear. So the rule here is for bone conduction vibrators, when the unmasked bone conduction threshold is better than either the air conduction threshold in either ear by greater than 10 dB, so at least 15 dB, then you need a mask. Let's revisit intraoral attenuation and cross-hearing. We know that with bone conduction stimulation, both cochlea are being stimulated. If both cochlea are stimulated equally, then intraoral attenuation is 0 dB. But if the test ear receives, for example, 10 dB greater stimulation than the non-test ear, then intraoral attenuation is 10 dB. Intraoral attenuation varies across individuals in frequency. We cannot know an individual's intraoral attenuation. Typically we don't. There are ways we can find that out, but we usually don't find this out. So we conservatively adopt minimum intraoral attenuation values. It's better to mask than to make an error. Cross-hearing for bone conduction testing happens often. Cross-hearing for air conduction testing happens, but less often. When the stimulus is presented to the test ear and it's heard by the non-test ear, cross-hearing has occurred. I've already mentioned that before. Again, cross-hearing occurs when the stimulus to the test ear minus the individual's intraoral attenuation exceeds the bone conduction threshold in the non-test ear. I'm just saying the same thing in a different way. Clinically, we compare stimulus presentation level to bone conduction threshold in the non-test ear, and we use our theoretical, really our empirical minimum intraoral attenuation values. We ask ourselves, could cross-hearing have occurred here? You can get a very rough idea of a patient's minimum intraoral attenuation by taking the unmasked air conduction threshold in the test ear and subtracting the bone conduction threshold in the non-test ear. But we always mask when we exceed the minimum empirical intraoral attenuation value. So we're comparing stimulus presentation level in the test ear by air conduction or bone conduction to the bone conduction threshold in the non-test ear, or the unmasked bone conduction threshold, because oftentimes that's what we have available to us at the time. If the difference exceeds the minimum intraoral attenuation for that transducer, again, 0 dB for bone conduction oscillator. If it exceeds the intraoral attenuation for that transducer, usually we say if it exceeds 10 dB for bone conduction. That's a little bit different than what we use for air conduction. If it exceeds the minimum intraoral attenuation for air conduction, being 40 to 55 dB for that transducer, then we present masking to the non-test ear. In these cases, we must assume the signal is being detected by the non-test ear, so we must apply masking noise to minimize contributions from the non-test ear. When to mask for bone conduction. Since intraoral attenuation for bone conduction is 0 dB, we never know which ear the unmasked bone conduction threshold represents. This only becomes a concern when there's a difference in hearing between the two ears. Bone conduction masking is needed when air conduction thresholds are poorer in one ear than the other, because unmasked bone conduction thresholds only represent the better cochlea. We don't know if the difference in hearing between ears is due to conductive or sensory neural differences until we mask. Here's an example of an audiogram. Compare the unmasked bone conduction thresholds to the left ear and the right ear. Notice that there is an air bone gap greater than 10 dB with the right ear, but not the left ear. With masked bone conduction testing, we don't know if the bone conduction thresholds are with unmasked bone conduction testing, we don't know if the bone conduction thresholds are from the right ear or the left ear. This begins to matter only because of the air conduction asymmetries. Now we need to apply masking to the left ear so that we can see if the masked bone conduction thresholds for the right ear are equal to or greater than unmasked bone conduction thresholds to the right ear. So again, we see that there's a gap between right ear air conduction thresholds and unmasked bone conduction thresholds for the right ear, really for the left ear either. We see there's a gap greater than 10 dB, so we need to mask for bone conduction for the right ear. It's as simple as that. Here's an example where things match up a little bit more closely. Here, air conduction thresholds for the right ear are the same as in the previous figure. However, now in this scenario, we have air conduction thresholds for the left ear and unmasked bone conduction thresholds more or less equal to the right ear air conduction thresholds. Here, there's no clinical value in masking each ear to obtain masked bone conduction thresholds because we know what they're going to be. If we mask these unmasked bone conduction thresholds, they're not going to change. We know they're going to match up because a masked bone conduction threshold is typically not worse than the air conduction threshold. Here's another example. If we imagine that masked right ear bone conduction thresholds had not yet been conducted for a moment, we can see that bone conduction masking is indicated for both ears in that scenario. If we choose to obtain masked bone conduction thresholds for the right ear first, then even though masking is indicated for the left ear, we know that the unmasked bone conduction thresholds probably represent the left cochlea, but we have to be cautious with this interpretation. The reason we have to be cautious with this interpretation is that ANSI reference standard levels were created with contralateral masking in normal hearing ears. This conservative approach would be to still mask the right ear to obtain masked left ear bone conduction thresholds, especially if emittance in the left ear was consistent with the sensory neural hearing loss. Again, there are audiologists that will stop here and say that those unmasked bone conduction thresholds represent the left ear accurately, but I would argue that if your admittance testing shows normal tympanograms and normal acoustic reflex thresholds, then you should probably mask for the left ear bone conduction as well. When to mask for air conduction. Compare unmasked air conduction to non-test ear for bone conduction, whether that's unmasked or masked for the opposite ear. When minimum intraoral attenuation of the transducer is exceeded, you need to mask. So 40 dB for many transducers like supraoral, circumoral, and shallow inserts, and 55 dB for inserts. The masking rules. Mask for bone conduction if the air conduction threshold in the test ear is higher than the unmasked bone conduction threshold by greater than 10 dB. Mask for air conduction if the unmasked air conduction threshold in the test ear is higher than bone conduction threshold of the non-test ear by 40 dB or greater for supraorals, circumorals, and shallow inserts, or 55 dB or greater for deeply inserted inserts. Here's another audiogram. In this audiogram, the purpose is to figure out where we need to mask at. This audiogram, the pluses in the table indicate where mask thresholds are needed. Hopefully this is intuitive. The arrow placed at 1,000 Hertz shows the possibilities of where that mask threshold might actually be. Here we need to obtain masked bone conduction thresholds in the right ear for all frequencies. You can see that masked bone conduction threshold for 1,000 Hertz might be at 10 dB, but it might be at 40 dB. At 2,000 Hertz, it might be at 10 dB. It might be at 45 dB. At 4,000 Hertz, it might be at 10 dB. It might be at 45 dB. At 500 Hertz, it might be at 5 dB. It might be at 35 dB. 250, it might be at 0. It might be at 35 dB. So because of that gap between unmasked bone conduction and the exceeding of the intraoral attenuation of the air conduction exceeding of the 10 dB air bone gap, greater than 10 dB difference between unmasked bone and the air conduction in the right ear, we know we need to mask for bone conduction. Here's another example. In this example, we need to obtain masked bone conduction thresholds in the right ear for all frequencies, but we also need to obtain masked air conduction thresholds for the right ear as well, where the minimum intraoral attenuation of the supraoral earphone is exceeded compared to unmasked air conduction threshold of the test ear to bone conduction threshold of the non-test ear. Notice the arrows at 1,000 Hertz extend to the limits for ACE air conduction. Since we don't know how much air conduction, we don't know much about air conduction, we also don't know much about bone conduction either. So in this case, we would want to obtain masked air conduction thresholds first, and it shows that here for air conduction thresholds, we need to obtain these at 1,000 Hertz, 2,000 Hertz, 4,000 Hertz, 8,000 Hertz. So obtain your masked air conduction thresholds first, then obtain your masked bone conduction threshold second. Then you'll have a much better idea of where your bone conduction thresholds will be. If we already had obtained our masked air conduction thresholds in the right ear, then we would have a better idea of what the limits of the masked bone conduction thresholds would be. Here's another example where potential air bone gaps exist in both ears. Here we do not need to obtain any masked thresholds for air conduction because we used inserts, or let's assume deeply inserted ear inserts, which have a higher intraoral attenuation than supraorals. But we do need to obtain masked bone conduction thresholds for both ears, usually the poorer ear first. So we need to obtain bone conduction thresholds for the right ear across the board, And then bone conduction thresholds for the left ear from 250 to 1000 hertz because we have an air-bone gap greater than 10 dB. Here's another example, a practice audiogram. We can see for supraoral headphones, we need to obtain right ear air conduction mass thresholds across the board, because when we compare 65 to 5, comparing unmasked air conduction in the right ear to unmasked air conduction in the left ear, 65 minus 5 is 60. That exceeds our 40. Here we look at 65 at 500 minus 0, that's 60, exceeds 40. Here at 1000, 70 minus 5 is 65, that exceeds 40. 60 at 2000 minus 15, here's a trickier one. 60 minus 15, that's going to be 45, still need to mask. Here's 60 at 4000 minus 15, still need to mask. And then 8,000, whereas with 8,000 hertz, we're not doing anything with bone conduction, we still need to mask at 8,000 hertz here. We have 65 minus 20 is also 45, so we still need to mask for supraorals or circumorals or shallow inserted inserts. Now, if we have deeply inserted inserts, that narrows things down. With deeply inserted inserts, we'd only have to mask at 250, 500, and 1000. Now for bone conduction, we have to mask for all the test frequencies in the right ear from 250 to 4000 hertz because it exceeds 10 dB. Here's another practice audiogram. In this example, for supraoral, if we were using supraorals, we would need to mask for air conduction at 4000 and 8000 in the left ear. But if we used deeply inserted inserts, we wouldn't have to. So as you can see the benefit of deeply inserted inserts. Now, can you fit inserts deeply into every ear? No, you can't. Sometimes you can only fit them in intermediately. Sometimes even only shallowly. It depends on the ear. Now, if we move on to bone conduction, for the left ear, we have to mask for bone conduction across the board for the left ear. From 250 to 4000 hertz, we have to mask across the board. Here's another audiogram. So if we look at supraorals for 250 to 1000 hertz in the left ear, we can see the difference between 250 at 45 versus unmasked bone conduction at 0. That's greater than 40 dB. 500 left ear, 45 dB. Unmasked bone conduction at 0. That's greater than 40 dB. 1000 hertz, 40 dB in the left ear versus 0 dB at 1000 hertz for unmasked bone conduction. That's equal to 40 dB. Still got to mask. So those three frequencies we have to mask for supraorals, circumorals, and shallowly inserted inserts for the left ear. Now for bone conduction, we have to mask for most test frequencies. It's really easier to point out where we don't have to mask. We don't have to mask at 4000 hertz for the right ear. That's the only place we don't have to mask for bone conduction. For every other bone conduction test frequency for each ear, we have to mask. Let's talk again how to mask for air conduction thresholds. We use the plateau method. This is the classical clinical masking technique, but other methods and variations do exist. Our goal is to eliminate cross-hearing in the non-test ear by administering sufficient air conduction masking to the non-test ear. Our initial masking level is 10 dB sensation level in the non-test ear. So 10 dB above the non-test ear when we're doing air conduction masking. Masking is always by air conduction, so the sensation level unit references the air conduction threshold of the non-test ear. Because narrowband noise maskers are calibrated an effective masking level, a 10 dB SL masker will raise the non-test ear threshold by both air and bone by 10 dB, or 210 dB for that matter. The tester is confident that the patient responds to the test ear stimulus or truly test ear thresholds when they have plateaued. That is, they are able to raise the noise by 15 to 20 dB without having to raise the test ear stimulus. There's a range of masking levels from the initial masking level to the start of the plateau that is referred to as undermasking. So the masking level that is below the initial masking level that is prescribed is called undermasking, where it's not going to do anything except maybe offer a little bit of central masking. The masking level at the start of the plateau is the minimum masking level. The masker level at the end of the plateau is the final masking level. Once the plateau is exceeded, the actual plateau may be larger than 30 dB. Overmasking may occur as the intraoral attenuation has been exceeded as the non-test ear stimulus crosses over to mask the test ear. This should be avoided. The maximum masking level equals the bone conduction threshold of the non-test ear plus the patient's intraoral attenuation value, which we do not often know, by the way, minus 5 dB. This is more of a theoretical formula. Again, remember, we don't know the actual intraoral attenuation of the patient unless we overmask, which we are trying to avoid. Here's an example of a diagram of how we might use a masking profile. So in this example, we have the left ear unmasked threshold at 0 dB. We have unmasked left and right bone conduction threshold at 0 dB. We have an unmasked right ear air conduction threshold at 50 dB. Now we see if we're using supraoral earphones, 50 dB is greater than the difference between the unmasked right ear and the unmasked left ear, or the unmasked right ear and the unmasked bone. It equals or exceeds 40 dB, so we need to mask. So what do? We start out at 50 dB in the right ear. And this here on the y-axis is our tonal presentation level to the right ear. On the x-axis is the masking noise to the non-test ear. So first, we start off by adding 10 dB sensation level to the non-test ear. So 10 dB sensation level would be bring the masker in the non-test ear and the left ear from 0 to 10 dB. That's going to put us at 60 dB HL. So let's look over here in the graph. It's going to test signal. We start at 55. We didn't get a response at 55. Then we moved up to 60. We're going up in 5 dB steps on the tone when we don't get a response. We got a response at 60. And then at 60, we have to raise the masker level. When we get a response, now we raise the masker level in 5 to 10 dB increments. Here we raise the masker level by 10 dB, going from 10 dB to 20 dB. So then we get no response, indicated here in the panel. No response here. Raise the tone by 5 dB. Now 65 for the. We're plotting this on this graph, the masking profile, as we go. Now we get no response at 65 dB while we have a 20 dB masker. So we raise the tone to 70 dB. Now we get a response, and it's at 70 dB with 20 dB of masking in the non-test ear. We plot it here on the masking profile. Now we raise the tone to 75 by 5 dB. 75 dB, we get no response. We raise that masker to 30 dB. We get no response. Now we raise the tone to 80 dB. We get a response. That's plotted here, 80 dB with 30 dB of masking. Now we raise the masker by 10 dB to 40. We get a response. That's plotted on the graph here. We raise the masker again another 10 dB to 50 dB. We get another response. It's plotted here on the masking profile. Going from 30 to 50 dB, we have a 20 dB masking plateau. we can say our threshold confidently for the right ear masked air conduction threshold is at 80 dB, represented by this triangle here. So 80 dB is our masked air conduction threshold in the right ear for this particular frequency. Now, you can also, in this example, we don't usually know this, but the author is giving us the patient intraoral attenuation value of 50 dB. So you can see whenever there's a difference of 50 dB, when there could be crossover between the test ear and the non-test ear. Here's another example. Since audiologists take a more conservative stance and prefer to establish a wider, some audiologists take a more conservative stance and prefer to establish a wider 30 dB plateau instead of the more common 15 to 20 dB plateau. So instead of stopping at the 20 dB plateau, in this particular audiologist kept going until they got a 30 dB plateau, a 35 dB plateau in this case, and they kept going above that. And they can see that it straightens out after that. You can see it slopes downward. So now that's your area of overmasking. So we've got undermasking at the initial masking level up until the minimum masking level of the plateau. Then we have the final masking level of the plateau, and above that we have overmasking. Like I said, the plateau method is a conservative clinical masking technique. A pragmatic way of viewing the plateau method would be that you need to be able to raise the masker by at least 15 dB without having to raise the tone for pure tone testing. After you master the plateau method, you may consider using variations of it like the step method or different methods like Turner method entirely to save time. No matter what, sufficient masking noise must be presented to the non-test ear by air conduction in order to elevate the non-test ear's bone conduction threshold so that it does not contribute to the resultant outcome of the test ear in air conduction testing. Back to masking for bone conduction thresholds. The method for obtaining masked bone conduction thresholds is the same as it is for obtaining masked air conduction thresholds, except your intraoral attenuation is 0 dB. One more factor may need to be accounted for, which is the occlusion effect, which refers to the increase in low-frequency ear canal SPL when the ear is occluded, and this would be the non-test ear being occluded. This results in lower bone conduction thresholds. To account for that, the occlusion effect is an additional added masking noise level to the non-test ear during bone conduction masking. The source of the occlusion effect is cartilaginous canal vibration during bone conduction stimulation. If you imagine you sustain a long E vocalization while alternating between closing and releasing your tragus, then you'll see what I'm talking about. You'll see that E vocalization is louder when you close the tragus of your pinna. When the ear is occluded by a supraoral earphone, the sound is created by the vibrations of the cartilaginous canal cannot escape the ear as it would unoccluded. This results in increased cochlear stimulation and lower detection thresholds artifactually, hence the need to add in a correction factor for the occlusion effect. Now with a deeply inserted insert earphone, deeply inserted, you don't have the occlusion effect. That's only if it's deeply inserted, though. If it's shallowly inserted, you do. Here's a shallow insertion where you do have the occlusion effect. Occlusion effect varies depending on transducer, depending on inserts placement, and transducer placement. The occlusion effect is related to the vibration of the cartilaginous canal from bone conduction and the trapped nature of that increased output causing increased cochlear stimulation. Here are more modern occlusion effect values. These differ slightly from the textbook. These are average. These are not average values. These are minimum values. If you want to find out the occlusion effect for an individual It's easy. You simply measure the bone conduction threshold occluded and then measure and subtract the bone conduction threshold unoccluded. As a side note, some of these occlusion effect values have come down over the years as more recent studies measure the psychoacoustic occlusion effect instead of the purely acoustic occlusion effect. Notably, you'll see supraoral headphones at 250 Hz need a lower occlusion effect correction than in previous textbook reports. For example, at 250, supraorals in our textbook say 20 dB. In the past, it said 30 dB in previous textbooks. These values in this chart are more up to date than what you see in the textbook. On exams, I'm not going to ask you a question where there's a conflict between the two. I may ask you for a range as an example, but not where there's a clear conflict between these updated values and what you see in the textbook. Notice with the circumorals how low they are. With the DD450, specifically circumoral, you can see it's close to zero. And also with deeply inserted inserts. But it's much more difficult to get a deeply inserted insert than it is to place circumoral headphones. Hence the benefit of using circumoral headphones, not having to take into account the occlusion effect for bone conduction masking. So what do I do to account for the occlusion effect when obtaining bone conduction mask thresholds? When you're using supraoral earphones, increase the initial masking level by the amount of the occlusion effect. The occlusion effect value used can either be individually measured or an average value. I said minimum value before, I meant average value. It's minimums for interoral attenuation levels, averages for the occlusion effect. Accounting for the occlusion effect is unnecessary if a conductive loss is known to be present in the non-test ear. If we don't know if there's a conductive component, then we do need to account for the occlusion effect. The key thing to remember is plateau, plateau, plateau. Here's an example on masking for bone conduction where we know the patient's interoral attenuation is 0 dB. In this case, it's pretty reasonable to expect that the actual interoral attenuation is near 0 dB. In this case, we have our unmasked bone conduction threshold for the right ear at 25 dB, and we have our unmasked air conduction for the right ear at 35 dB, unmasked air conduction for the left ear at 55 dB. Again, we're masking for bone conduction for the left ear in this case. That's why we see these left ear bone conduction symbols on the graph. So we start out by having our masking level set to 10 dB above what our unmasked right ear bone conduction threshold was. It was at 25 dB. Then we set our masker 10 above that at 35. Let me rephrase that here. I think I misspoke. Our unmasked bone conduction threshold for the right ear was at 35. For the left ear was also at 35. Our occlusion effect was 10 dB at this frequency, and we're also adding in 10 dB is for our above threshold sensation level for our starting masking level for the right ear. So for the right ear, non-test ear is our masker. We're starting at 35 dB plus 10 equals 45 dB plus 10 for the occlusion effect is 55 dB. That's our masker in the non-test ear toward the right ear here. So 55 dB is the masker. Our bone conduction threshold, non-test ear, our initial response with 55 dB of masking to the right ear is going to be a response of 45 dB on the tone in the left ear. So that's what we see here. 45 dB of tone is our initial response with 55 dB masker. So with a response at 45 dB, that means we increase our masker level from 55 to 65 dB, we get no response. So we increase our tone to 50 dB, we get no response. So we increase our tone to 55 dB, keeping our masker at 65 dB. And then we get a response. Now we increase our masker to 75 dB, we get a response. We increase our masker to 85 dB. So we have a plateau of 20 dB, going from 65 dB up to 85 dB. We have a 20 dB plateau, and that's with our threshold here at 55 dB. So our masked left ear bone conduction threshold is at 55 dB, and that you should be able to follow it in the table here on the right hand side. So step-by-step masking procedures with the plateau method. Present the narrowband noise masker to the non-test ear and via air conduction at the initial masking level, which is the non-test ear air conduction threshold, plus 10 dB. Also add the occlusion effect for bone conduction testing. That's going to depend on the frequency and the transducer. Consider checking for overmasking when bilateral air bone gaps exist. How do you check for that? Non-test ear initial masking level minus test ear for bone conduction. Is that greater than minimum intraoral attenuation? If it is, then you're probably, or could be, overmasking. You don't know for sure, but you could be overmasking if non-test ear initial masking level minus test ear bone conduction threshold is greater than the minimum intraoral attenuation level for that transducer. Then we reestablish threshold, raise the masker in 5 or 10 dB steps each time the patient responds, raise the tone in 5 dB steps each time the patient does not respond. Continue the previous step until you have raised the masker by at least 15 dB or greater in order to obtain a plateau with consistent responses at each step, indicating you've plateaued. If no plateau can be reached, cease testing when discomfort or system limits are approached, and then you have a masking dilemma on your hands. Here's another example for masking, with insert earphones being used. We have unmasked bone conduction thresholds for the right and left ear, unmasked left and right air conduction thresholds. We see a large asymmetry in unmasked air conduction thresholds, with right ear being a lot worse than the left ear. So we use the plateau method, present 1000 Hz narrowband noise to the left ear. Remember the initial masking level to the non-test ear is the air conduction threshold plus 10 dB. What about the occlusion effect? We only add the occlusion effect for masked bone conduction, not masked air conduction. So air conduction at 1000 Hz in the left ear, non-test ear is 0 dBHL, which means our initial masking level is 0 dBHL plus 10 dB, which is 10 dB EML. Unmasked air conduction threshold in test ear was 75 dBHL, so you reestablish threshold with the masker applied to the non-test ear. After we reestablish, we see that the test ear threshold shifts from 75 to 85 dBHL. Now what do? We add more masking. How about a 5 dB more masking? Actually, in this case, it looks like we added 10 more dB of masking going. Actually, no, we'll add 5 more dB of masking, going from 10 to 15 dB effective masking level. And we received a response at 90 dB. Here we see another 5 dB shift in threshold, so it's at 95, but that's with 20 dB of masking. You see another 5 dB shift. It's 100 dB with 25 dB of masking. We keep having to go up on the masker and going up on the tone accordingly. Now we finally get to go up on the masker without having to go up on the tone. Just going from 25 to 30 dB on the masker, staying consistent on the 100 dB tone. Going up to 35 dB on the masker, staying consistent at 100 dB on the tone. Still no shift. Raise the masker another 5 dB. So we've shifted the tone from 75 up to 100 dB, but we've stayed constant at 100 dB on the tone, and we have a 20 dB plateau going, or 15 dB plateau going from 25 to 40 dB. That's enough for us to call that threshold, for that air conduction threshold. Can we stop here? Yes, we can. So this is our area of effective masking, from initial masking level to final masking level. The patient response level is a function of presentation level of masking noise. Areas of undermasking are here to the left, below the plateau, that's undermasking, and effective masking or plateauing is the flat line, the horizontal line. Here is our masked right ear air conduction threshold at 100 dB using insert earphones. Now we move on to obtain masked air conduction thresholds for other frequencies. This is what we get when we mask for other frequencies. You can see we've had a significant shift across the board for right ear air conduction mask thresholds. Now our goal is to try to get masked bone conduction thresholds for the same patient for the right ear as well. So patient response level, we started our masker level here at 10 dB and our tone at 20 dB. What do we get? With 10 dB of effective masking level, you reestablish threshold. The new threshold is 20 dBHL. Are we done? No, we must plateau. Plateau, plateau. Now add another 5 dB of masking noise to the non-test ear. We added 5 dB of masking noise, and we shifted our threshold by 5 dB. Now what? We raised the masker another 5 dB to 20 dBHL, and there's no response. What do we do now? We raise the tone. We can see now we continue to raise the tone when we have no response, and the masker when we do have a response. What are we waiting for? A plateau. Have we plateaued yet? How about now? No. Now we have a masker at 70 dB. The patient doesn't respond to the tone, but for this audiometer, the maximum output limit for bone at 1000 Hertz is 70 dB. So what do we do now? 70 dB, we have no response, with no response, at 70 dB, with the masker level at 70 dB as well. Under these circumstances, we ask ourselves, could we be overmasking? Yes, it's possible. Let's say hypothetically we are not, because overmasking is not a risk in all situations. We still would have no idea if this is mixed or sensory neural hearing loss. So here, no responses to masked bone conduction stimuli for the right ear at equipment limits. It's not recorded here on the audiogram, but that is the result here. No response for masked right ear bone conduction thresholds at the equipment limits. We know it's not a pure conductive loss because the maximum conductive loss is around 60 dB. So it's got to be either mixed or sensory neural. Conductive loss cannot be greater than intraoral attenuation. That's how we know that 60 dB is close to the max for the conductive portion of the loss. Here's a new audiogram, example 2 here. We've got an easier audiogram to deal with here. We've got left unmasked air conduction for in right unmasked air conduction, left unmasked bone conduction, right unmasked bone conduction, compared to the unmasked air conduction for the right ear, to both unmasked air conduction for the left ear and unmasked bone conduction thresholds. Could cross-hearing be occurring here? Do we need to mask for air conduction? What frequencies? Let's start at 1,000 hertz using the plateau method. So what's our initial masking level at 1,000 hertz and presented to which ear? We're using supraoral earphones here. So we've got 10 dB of narrowband noise placed in the left ear. Threshold is reestablished in the right ear. How do we interpret this? Where do we go from here? Do we raise the tone or the noise now? We raise the noise by another 5 dB. What happened? Did we get another response or no? When we raise the masker from 10 to 15 dB, are we done? What do we do now? Yes, we raise the masker from 15 to 20 dB. What happened? What do we do now here? Go from 0 to 20 dB. Looks like we've plateaued. We've got masked air conduction thresholds. That was just for one particular frequency, but we replicated that for all frequencies. And these are our masked air conduction thresholds for the right ear. Imagine that we plateaued in the same way for all test frequencies for the right ear. After determining that 40 dBHL is our masked air conduction threshold at 1,000 hertz for the right ear, we continue on complete masked thresholds at other frequencies. Here's our audio. Now what do? We need to check if this audio in front of us, what do we compare? Let's start at 1,000 hertz. What's our initial masking level? Which ear do we present to? Do we determine that initial masking level by referencing the air conduction or the bone conduction threshold of the non-test ear? So we start at 1,000 hertz here. With 10 dB of masking, we reestablish threshold, and we rewind for a moment here. So we know we don't need to do any masking for the left ear air conduction. We need to mask for bone conduction now. And we'd only need to mask for right ear bone conduction, not left ear bone conduction, because we don't have any air bone gaps for the left ear. So for right ear bone conduction, we have 10 dB of masking. We reestablish threshold. What is it? And now what do? We raise the masker by 5 dB. Now our bone conduction threshold is at 25 dBHL. You can see right here at 25 dBHL our bone conduction threshold with 15 dB of masking noise. We repeat the process of raising the masker noise until we get no response, and raising the tone until we get a response, until we have a response at 40 dBHL. We'll keep going here. We've got a response at 40 dBHL with a masker at 30, 35, and 40 dB. Is this the start of a plateau? Sure looks like it. We continue to raise the tone and raise the masker using our masking rules until we have passed our plateau. Now we have an increase in threshold for each corresponding increase in the masker. Why has our mask threshold shift for higher masker levels? It's because we're overmasking. So we have a very nice plateau going from 30 dB in noise down to 80 dB of noise. We have a 50 dB plateau here, more than enough. But just for example's sake, we can see that we are reaching into overmasking now. So we've plateaued, and now we're into overmasking. You can see an area of undermasking based on the information we know what the true mask threshold is in the right ear. So we also know if the site of lesion is conductive, mixed, or sensory neural. So we can be confident of that. We see undermasking here, effective masking here in the middle where it's plateauing, then we see overmasking. So we can see we have right ear bone conduction thresholds across the board matching up with our right ear masked air conduction thresholds. So we have a sensory neural hearing loss in the right ear. Here are cases when masking does not work. Unmasked bone conduction thresholds are present within the moderately severe region, but when we apply masking to the non-test ear, we cannot increase bone conduction output further due to equipment limits. In this case, we need to use admittance to help. In this example, we also have other problems. We have vibrotactile responses, very likely at 500 hertz. We have air conduction, loudness, discomfort levels for the non-test ear. So it's only so loud we can go with the masking level noise. So we have equipment limits, we have loudness, discomfort levels, and we have vibrotactile responses. So these are all challenges we have with masking in certain situations, like bilateral mixed hearing loss or bilateral conductive hearing loss as well. In this case, bilateral mixed hearing loss. So the amount of masking noise needed to achieve effective masking is greater than the audiometer or transducer combo can output. And we'll see something like this. This is bilateral conductive. This is a different audiogram using supraoral earphones. Bilateral conductive with large bilateral conductive components. By the time we reach the level to overcome undermasking, we're in the area of overmasking. So there is no effective masking region. We go from undermasking to overmasking directly, and we see a straight line. So this is a masking dilemma. Let's talk about masking for speech for a moment. Shift gears from pure tones now to speech testing. Masking is required whenever the signal in the test ear exceeds interoral attenuation and cross-hearing by bone conduction is possible in the non-test ear. For speech audiometry, a speech noise masker is utilized. It's much more broadband. Comparison should be between speech presentation level minus interoral attenuation and best bone conduction pure tone threshold in the non-test ear. For supraorals and circumorals, we use 40 dB as our minimum interoral attenuation, which is what we're using in the formula here. So presentation level minus minimum interoral attenuation of 40 dB, and we take into account the best bone conduction threshold in the non-test ear. For deeply placed inserts, we talked about 55 dB as our interoral attenuation minimum. So masking for SRT and word rec. If masking is needed for SRT, then it is also needed for word recognition, but the converse is not necessarily true. If masking is needed for word recognition, it doesn't mean you need it for SRT. Effective masking level is the highest presentation level in the test ear, minus 20 dB. That works in cases where it's not a conductive loss and not a mixed loss. That works in a purely sensorineural loss example. The above formula may result in overmasking with supraorals at high presentation levels, but it can work as long as we're not overmasking with sensorineural loss. The above formula works fine so long as there's no earbone gap, again, not greater than 10 dB in the non-test ear. Here's an example. We've got effective masking level of 80 dB minus 20 dB equals 60 dB HL. So will this work, or will this be a problem? Presenting speech stimulus at 80 dB in the right ear using insert earphones. Is overmasking possible with inserts? It depends on how shallow or deep that insert is. That's one question. Is it possible with supraorals? That's another question. Well, with supraorals, yeah, it is possible. So if we take a 60 dB masker in the non-test ear, in the left ear, and we have a minimum interoral attenuation of 40, 60 minus 40, 20 dB could cross over, and it could be overmasking. That's possible. What about with deeply placed inserts? Is it possible there? 80 dB minus 20 dB for our 60 dB masker, 60 minus 55, 5 dB. Is it possible that we have overmasking? It's possible, but it's probably not very significant. It's possible, but not likely, and not likely to be very significant if it is overmasking with inserts. If the air-bone gap in the non-test ear or a high presentation level, then the effective masking level is presentation level minus intraoral attenuation plus largest air-bone gap in the non-test ear plus a 20 dB safety factor. So that would be our presentation level for the masker. So ideally, that last formula I was giving you was mainly for sensory neural losses, but we didn't have a sensory neural hearing loss in the right ear. So that wasn't the ideal formula for the right ear. So again, let's go back to the ideal formula. Presentation level, which was 80, minus intraoral attenuation. Let's say a deeply placed insert at 55. 80 minus 55 is 25, plus the largest air-bone gap in the non-test ear. Well, the non-test ear was 0 dB. The largest was a 5 dB air-bone gap. So that wasn't very much at all. So going back to the formula, 80 minus 55 is 25, plus 5 for the largest air-bone gap in the non-test ear. So that puts us at 60, plus a 20 dB safety factor. That puts us at 80. That's a pretty high presentation level. I probably wouldn't do that high of a presentation level because then you run the risk of overmasking. I would probably stick with a 60 dB presentation level for the masker and the non-test ear in that scenario. Masking dilemmas are possible with word recognition and likely with the same populations, bilateral conductive and bilateral mixed hearing losses. Let's look at this example of a conductive hearing loss in the right ear and normal hearing in the left ear. No need to mask for SRT. I know we don't have that shown here. No need to mask for SRT. Comparison between SRT, the right SRT with the best bone conduction threshold does not exceed 40 dB. In this case here, our SRT is 25 dB. If we compare that to our pure tone average, which we have to calculate manually, compare it to the, actually we're not comparing it to the PTA, we're comparing it to the best bone conduction threshold in the left ear. Best bone conduction threshold in the left ear is 0 dB. So 0 dB, 25 minus 0 dB does not exceed 40 dB for an insert or a supraoral, so no need for masking for SRT. Left ear SRT, 5 dB. Again, no need. If we compare it to the best bone conduction threshold in the right ear, that's also at 0 dB. No need for masking for the SRT. Is there any indication to mask the left ear and obtain a masked right SRT when using supraorals or inserts? I think we already answered this question, and it's no. We don't need to mask for SRTs in this case. Masking is needed if the unmasked SRT in the test ear minus the best bone conduction in the non-test ear is greater than or equal to the intraoral attenuation level, which we already established here. 25 minus 0 is 25, and 25 is less than 40. For supraorals, 0 dB minus 0 is 0, and 0 is less than 40. Same thing with inserts. If we have a deep insertion on the insert, 25 minus 0 is 25, and 25 is less than 55. Looking at the left ear, 0 minus 0 is 0, which is also less than 55. So no need to mask for SRTs for either transducer in this situation. Let's say we need to do word recognition. Now we need to check to see if we need a mask. We're just going to say we're going to present 30 dB above SRT. Why are we doing 30 dB above SRT? Well, in the left ear, We're doing it above at 30 dB above because it's normal hearing. So 30 dB above can be sufficient. Maybe we need to do 40 dB above, but in our case, we'll try 30 dB above, and we'll see how that goes. And then no masking is needed for that case, because 35 minus the best bone conduction threshold in the non-test ear is 0. 35 minus 0 is 35, and that's less than 40, so no masking for either transducer for the left ear. How about the right ear? The right ear, we had an SRT of 25 dB. This was a purely conductive hearing loss, so we can do 30 dB above for a purely conductive hearing loss. So it's 55 dB is our presentation level. Do we need to mask? 55 dB minus best bone conduction threshold in the non-test ear, which is 0. 55 minus 0 is 55. Do we need to mask with superaurals? Yes, we do, because 15 is greater, because 55 minus 0 is 55, and that's greater than 40. Do we need to mask with inserts? Well, barely, just barely. 55 minus 0 is 55, and that equals the minimum intraoral attenuation for inserts. So just barely in that right ear do we need a mask for word recognition. And this formula bears it out, that exact same thing that I mentioned a moment ago. Now, how much masking do we need to provide to the non-test ear? That's the next question. We know we need to mask when we're, for the right ear, doing word recognition, we need to mask. So the presentation level to our test ear is going to be, the masking level to our non-test ear is going to be the presentation level to our test ear, which is 55, minus the intraoral attenuation, which is 40 for superaurals and 55 for deeply placed inserts, plus a 20 dB safety factor, plus the largest significant air-bone gap in the non-test ear. And that largest air-bone gap in the non-test ear, let's see what that appears to be. It looks like that largest air-bone gap in the non-test ear is, non-test ear being the left ear, largest air-bone gap. Is that 0 or 5? Let's see. Really 5 is the largest air-bone gap that I'm seeing. But in here they calculated it, for some reason they have 0 as the largest air-bone gap. But in any case, it's not a very significant difference either way. Maybe they say, maybe the key terminology here is largest significant air-bone gap. Air-bone gaps 10 dB or less are not considered significant. That's likely why they're factoring it out as 0. So we have 55 dB minus 40 for our intraoral attenuation, plus 20 plus 0 equals 35 dBHL for the masker level with supraoral earphones. And now with inserts, 55 minus 55 plus 20 plus 0 is 20 dB with inserts. So we have less masking to the non-test ear, to the left ear, with inserts than we do with supraoral earphones. And so again, the key thing here is, yes, there is an air-bone gap of 5 dB, but it's not significant because it's less than 10 dB. Here's another case for masking for speech. We've got our right ear unmasked air conduction thresholds, our right ear unmasked bone conduction thresholds, our left ear unmasked and masked air conduction thresholds depending on the frequency, and our left masked bone conduction thresholds. So now we need to mask for speech. Case 2, do we need to mask for SRT? Our right ear SRT is 0 dBHL. Our left ear SRT is 40 dBHL. Is there any indication to mask the right ear and obtain a masked left SRT when using supraorals or deeply placed inserts? No need to mask for the right ear for SRT, but yes for the left ear is the answer to that. So right ear, no need to mask for our SRT. Left ear, we probably do need to mask for our SRT. Why? Let's take a look. So masking is needed when the unmasked SRT in the test ear minus the best bone conduction threshold in the non-test ear is greater than intraoral attenuation or equal to intraoral attenuation. So we had for the right ear 0 dB minus 30, which was the best bone conduction threshold in the left ear, the non-test ear. 30 was the best bone conduction threshold. So 0 minus 30 equals negative 30, and adding in negative 30 is less than 40 dB. Masking is not needed. Now for the other ear, for when we our left ear SRT, 40 dB with supraoral earphones, 40 dB SRT minus 0 dB bone conduction threshold, which is the best bone conduction threshold in the non-test ear, which is the right ear. 40 minus 0 is 40, and 40 is equal to 40 dB, which is our minimum intraoral attenuation in the left ear. I'm sorry, in the right ear. So we do need a mask for SRT in the left ear, rather. In the left ear, we need a mask for SRT. With insert earphones, masking is not needed. That makes a difference because we barely need a mask for SRT in the left ear just because we equal our intraoral attenuation level. Now that we've raised our intraoral attenuation level by switching to inserts with 55 dB for deeply placed inserts, we don't need a mask there anymore, but we do need a mask for our left ear SRT. So here's our masking formula. Presentation level to the test ear to the left ear, minus 20 dB. So 70 dB minus, where do we get 70 from? Let's start there. Let's start where we're getting 70 from. Our SRT was 40. We're adding 30 to that. So 70 is our presentation level, minus 20 dB for our safety factor, minus 20 dB. And that gives us 50 dB HL. That is our masking level to our non. Sorry, let me rephrase that again, because we're dealing with the sensory neural hearing loss in the left ear. We can do presentation level minus 20 dB. So we're presenting 70 dB presentation level to the left ear. We were doing 30 dB above SRT. So 70 dB to the left ear, which should be sufficient to establish PB max, minus 20 dB, and that gives us 50 dB of masking to the non-test ear, which is to the right ear. So how does that break down? We can take the presentation level to the test ear, 70 dB HL, minus the intraoral attenuation for supraoral earphones, 40 dB, that equals 30, plus 20 for the safety factor, plus 0 for the air-bone gap, significant air-bone gap. That gives us 50 dB HL for the masking level to the non-test ear on the right side. Why is the presentation level 70? We just added 30 dB to the SRT because we were guessing that our masked SRT wouldn't shift nearly that much. Now for word recognition testing, so if a presentation level at 70 dB HL, do we need masking here? With supraorals, with inserts. Right ear presentation level is 30 dB. Because we're going, it's normal hearing in the right ear. We're doing word recognition at 30 dB above. And left ear presentation level, we're doing 30 dB above SRT, so 70 dB in the left ear. So do we need masking for word rec for these guys? For supraorals and for inserts. For the right ear, no masking is needed. That's pretty straightforward on the right one. We don't exceed our interoral attenuation level. But for the left ear, let's break it down. For the left ear, presentation level of 70 minus best bone conduction threshold in the non-test ear, which is 0 dB. 70 minus 0 is greater than 40 dB, so we need masking when we're using supraoral earphones for word rec. What about for inserts? 70 minus 0 is greater than 55. We also need masking with insert earphones. So when we're doing word rec in the left ear, the 70 dB presentation level, we do need to apply masking to the right ear. Because it's sensory neural, we can just take 70 minus 20 and apply 50 dB of masking in the non-test ear. Let's see if that's what the formula breaks out to be. 70 minus 40 is 30, plus 20 is 50. So that's what I just mentioned a moment ago. Although with inserts, we can use 50 if we want. We can use a lower masking level if we choose to do so. 70 minus 55 plus 20 plus 0 is 35 dBHL. So we can use less masking. We don't have to, but we can use less masking in the right ear when we use inserts if we choose to do so. And usually less masking is preferred because you have a less central masking effect and less risk of crossover. That's all I've got for masking for speech testing here. Thank you.